Hello, I'm Dr. Maury Markman from City of Hope. In our last session, I highlighted what I label the unrelenting unreality of cancer care finances in the United States by employing the childhood fable, The Emperor's New Clothes, to emphasize both the magnitude of the situation and the fact that developing meaningful solutions always appears to be a problem we will somehow deal with tomorrow, not today. It's important to emphasize that this situation is not really new, and it is developed, even though it's now incredibly rapidly accelerating, but it developed decades ago. I remember personally in the 1990s when the wonder drug paclitaxel, known as brand name Taxol at that time, breached the $1,000 a dose mark. Now, I'm not absolutely certain it was the first drug that cost $1,000 a dose, but it certainly was the one that got the most publicity. How could we charge $1,000 for a single dose? But to emphasize the point that, yes, it was very expensive, but in fact, treatment was very limited in duration. So in ovarian cancer, my area of clinical interest and focus, one might give 6 courses if one was fortunate enough to have a patient that responded that long. Rarely later, more than that, very often less than that, both because of the toxicities of the drug, but more relevant, unfortunately, because of the limited effectiveness. So the therapy was stopped. So yes, it might have been $1,000 a dose, but it might have been for 4 to 6 cycles. And it was uncommon to give second-line therapies. In fact, the second-line therapies were often the generic drugs, not very effective, didn't give very long, but they were relatively inexpensive. Today, we are in a different era. More and more cancers are becoming, advanced cancers are being chronic disease processes, where we need to give therapy for years. And often the second, third, and fourth line drugs are the most expensive. We are increasingly using a maintenance therapy. Individual drugs may cost not $1,000 for treatment, but $20,000 or more per month or per cycle. And such drugs, because they're active and much better tolerated, maybe taking for a year, 2 years, or even longer. And we are increasingly using combinations of these active, novel drugs that are safe or relatively safe to be given in combination. So what happens? And we're on the verge of this. We are routinely giving not 1, not 2, but perhaps even 3 drugs, novel drugs, at $20,000 plus per month, plus supportive care medications, plus perhaps drugs to prevent side effects, plus the cost of managing these side effects. And I will add, what happens when we finally develop second line or third line CAR T-like therapeutics for solid tumors, with the costs of such strategies likely to be in the hundreds of thousands of dollars per treatment? How long can this continue? That is my question. In the final segment of this admittedly very difficult subject, I will offer some thoughts, suggestions to consider as we move forward to try to begin to deal with this situation. And I thank you for your attention.